My name is Dr. Edward Ngwenya, and we will be discussing breast reconstruction in this session. So it's just going to be a high-level discussion just on the principles of breast reconstruction, just focusing on the overarching principles. Let's perhaps start by using a case scenario. Here's a 40-year-old female who presents with a left mastectomy defect, and she requests reconstruction. So, what are your considerations for this patient? Well, I think the first thing you'd want risk factors. So you want to stratify this patient based on strong, moderate, and severe risk factors. So you'll put on that criteria because this will give you an idea of recurrence. Secondly, you want to know what the histology, original histology was, which of course would give you the type, the receptor status, and the tumor biology, where you could then be able to deduce further recurrence risk from that. Was there radiotherapy that was given, or radiotherapy was omitted? And of course, did the patient have an axillary lymph node dissection or radiation in the axilla? So those are more or less the important, considerations that you'd like to know. Of course, there are other patient factors that you'd like to know, your comorbidities, etc. But we're just giving a high-level overview. So what is the timing of reconstruction? I think let's start off there. We can divide it into immediate versus delayed. So immediate breast reconstruction, right in the setting, we remove the cancer and then we do the reconstruction in the same setting. So what are the advantages of immediate reconstruction? Well, psychology is one. Psychologically, the patient is much happier, receives, the ablative surgery and has reconstruction in the same setting. We found that it gives better aesthetics. Why? More natural. The IMF is preserved. There's no, mismatch, because most of the time, generally, what we'd be doing is skin sparing mastectomy. It is a single stage, so that's always better, minimizing the aesthetic, or rather anesthetic risks of another operation. And in some patients, you may actually get away with no symmetrization that you would have to do to the other breast as you when compared to having it delayed. And of course, there's less tissue that is required in this instance. So those are your main advantages of immediate reconstruction. There are disadvantages, of course. Oncologically, you do not have a permanent histology. So it may be risky. You've taken a flap, you've put it there, and then the permanent histology comes and says, there is now tumor that's still there that was not completely removed. So that's one of the disadvantages. The other, we are not sure about the viability of the flap. For example, you do a skin sparing mastectomy, and then immediately you put in an implant, for example. And those flaps are thin, they may not survive, and then you find that the implant starts, extrudes, or the flap that is left there, starts to die off. We have flap necrosis. So that is one of the things. Of course, we do have newer ways of monitoring that we can use. And also DXT. We don't know whether the patient might need to have radiotherapy, and in the event that they have radiotherapy, it may now distort your reconstruction, because you are having DXT directly on that flap that you have put, so the eventual outcome might be a problem. So those are just some of the broad disadvantages. Of course there'll be more, but as we said, we're staying high level, just the broad disadvantages of an immediate reconstruction. And what are the options that we have for immediate reconstruction? So whenever we go, first thing, you'd always speak about timing, as we have, and then you go and speak about the options. So timing, immediate or delayed. Options for immediate, it's autologous or alloplastic. That's where now we put in an implant, mainly, largely. That's what we are speaking about. And what are perhaps the options for an autologous repair? Let's maybe just sort out some definitions so that we all understand and we're on the same page. Few things that people get confused. There's breast conserving therapy, okay, BCT. Now, breast conserving therapy includes breast conserving surgery, which is lumpectomy. So you do a wide local excision with a margin. What is your margin? No ink on the on the specimen. So that is our margin. And then the package with this is radiotherapy. So there are indications for BCT. We're not going to get into that, but generally, if there won't be major distortion to the breast, less than 20%, in a large breast, and we can remove that mass, then we are happy. But the package is radiotherapy will then need to follow. Then we've got oncoplastic techniques, and we can break the word in two. Basically, it's using the principles of oncology. So you want complete cancer or tumor resection following those principles, but also using plastic surgery techniques to reconstruct in that very setting. So that's when we now speak about, we've removed a large piece, we speak about volume replacement then, techniques that we can use, or volume displacement techniques. Now that's a concept that gets many confused. Of course, they become, we start to have a bit of controversy with it, and that's why we go further into typing it, less than 20%, type 1, type 2, 20 to 50, etc. In order to just further try to define this oncoplastic surgery. And then, of course, now we've got techniques where we go now full autologous. We've done a complete, in mastectomy, we've removed the cancer, and then we have to now reconstruct. So for autologous, what are our indications for an autologous reconstruction? And broadly speaking, patient's request always comes top of the list. DXT is another indication. When someone's going to receive radiotherapy, you need tissue cover. Unilateral breast surgery, so we're not going bilateral, so unilateral. And obesity is one of the indications. So that already almost gives you the indications for an alloplastic or implant-based repair, being, your thin patient, bilateral reconstruction, or unilateral reconstruction without ptosis of the breast. And if a patient is not going to receive radiotherapy. So those are the indications for implant-based alloplastic reconstruction. What are the autologous options that we have? Now, when we speak about the options now for autologous, the way to break it, there are many ways, but the way I propose that we break it, then we base it on anatomical site. So for autologous, it can be the abdomen, it can be the back, it can be the thigh, it can be the buttocks that we can use. The flanks, sometimes, you can also use like your Rubens flap. We know that Flemish artist Ruben, who drew these, call it voluptuous women, who had the saddlebags, so this flap uses this. It's based on the deep circumflex iliac artery, to utilize the excess skin on the flanks. So that's those are your options. So let's break it down. Let's go bit by bit. Let's start with the abdomen. What are the advantages of using the abdomen, or flaps from the abdomen, for your autologous reconstruction? Volume is number one. You've got a lot of volume. So volume is a big tick on that. And aesthetics also, we know from that we've got good aesthetics outcome from that, both on the donor side and also on the recipient side, because you kind of win on the donor side, receiving a tummy tuck in the same setting. So those are your two main advantages of the abdomen. And as you would see, the gold standard is actually that for autologous reconstruction. The world gold standard actually being your DIEP flaps now currently. But the tram flap has been a gold standard for a very long time. So what are your options in the abdomen? 3 options you have. Tram, which is your transverse rectus abdominis in myocutaneous flap, and then the DIEP, which is your deep inferior epigastric perforator flap. So you don't take muscle, you are only above the rectus, anterior rectus sheath, taking the rectus, the fat. And a CEP, of course, instead of using your deep inferior, rather using your superficial inferior epigastric artery perforator. And of course, there are criteria for that. When would one use that? And that's generally when you follow, if you look at the laws that pertain to vessels, if there's a better vessel there, following the law of equilibrium, that if I'm dissecting my DIEP and I see my vessels are small, as you would notice when we speak further about the criteria that's proposed. If my vessel is small, less than 1.5 millimeters, I may then, in knowing the law of equilibrium, it means the CEP might be bigger, and then you'd use that instead. So let's start with the tram flap. Now, when we discuss these flaps, the tram, we can divide it into either pedicled or free. So what are the issues with the tram? Look, when we had it on pedicled, it's this large flap. The main thing we're worried about, look, what is the reliability of this flap? Especially when doing breast reconstruction. And so Hartranft then came with a criteria to use for patients to say, look, because we worry about this, I am proposing a criteria that you can use to guide you. And any patient that falls out of this criteria, or any patient, as per the scores, that scores badly on this, should not have a tram flap. Now, what are the criteria, the Hartranft criteria that he brought? And I like to use a simple mnemonic: psoas muscle, PSOAS, psoas muscle, which is just the capital letter M. PSOAS, which is psoas M. And what does P stand for? So P in this mnemonic will be the psychological status of a patient. You're not going to put it on an unstable, emotional state patient who has a life crisis or substance abuse or any psychiatric disorders, personality disorders, hard breath excludes those. S stands for surgical experience. So that generally says if you've got less than 10 tram flaps, already now it scores 1, The O would then stand for obesity. And he calculates that as moderate, less than 25% above IBW, or severe, more than 25% over. So obesity then stands as 1 where you'd score a patient. A would then stand for abdominal scars. So if there are abdominal scars, such as a patient who's had a disruption to the vascular perforators, like in a patient who's had a Kocha incision, or a previous abdominoplasty. Now these are contraindications to a tram flap. The other S then would stand for smoking. So any patient who is smoking, because that then gives you small vessel disease, with smoking. So you would then group them: light to moderate smoking, heavy smoking, chronic, which is 10 to 20 pack years, or worse, chronic heavy smoking, more than 20 to 30 pack years. And so you would then divide on that as small vessel disease. And then lastly, M would stand then for medical disorders. So any major systemic disease like chronic lung disease, severe cardiovascular disease, those would be your exclusion criteria for a tram flap. So now that we've defined and we've said, look, we are afraid of reliability, how can we then instead improve our reliability? There are 5 ways that you can improve reliability. 1, it would be to delay a flap. So how do we delay a flap? Strategic delay is something that you can use here by interrupting one of the vessels, maybe the deep inferior epigastric artery. You ligate it for 2 weeks and then you raise the flap. That would have strategically delayed the flap and changed our angiosomes. You remember Hartraf defined the angiosome as the one that's supplying being 1, opposite the other side being 2, and then just next to it being 3. But Holmes also modified it, and then we've got Taylor, who won't go through it here, but those are the angiosomes that we speak of. So delaying, supercharging it, meaning as I move the flap to the recipient site, I will anastomose it, not just on one anastomotic site, but perform another anastomosis on the other side, thus supercharging the vessels. Turbocharging is the third way that you can then do. What is turbocharging? Turbocharging is, think of it like a GTI. The power is within. So you then take the anastomosis and re-anastomose it within itself. That's turbocharging within itself. And then the fourth way, you can translocate the flap as you raise it. Now, what does that mean? We know that most of the blood supply, we get more from the peri-umbilical perforators. And of course, we know our standard tram flap would be along the Penty line and just going just above the umbilicus. But now this then says, let's move it higher above the umbilicus. What will that do? Of course, it takes our incision site, inferior incision site higher, so the scar may be more visible above the Penty line. That's the trade-off, but that will increase the perforators that you can catch. And then, of course, the last option, which is number 5, would be a free flap. I mean, if you do it as a free flap, then that works. Because you get then all the benefits you would then anastomose it directly on itself. So those are the 5 ways that you can you can improve the reliability of a tram flap. And of course, when we speak of a free flap, now we speak about recipient vessels. And broadly speaking, 2 are used. It would be the internal memory. We know from the 3rd, it starts to get smaller. So on the 3rd rib, you remove and then you anastomose it there. Or the thoracodorsal. Which one do we like? Of course, if you compare the 2, the one that would come up higher is the internal memory. Why? You can shape the flap easier, because remember we always speak about the medial projection. We don't like the lateral projection aesthetically, and so it's ideal with your internal memory for shaping. Better flow, so there's increased flow, there's better flow when you compare it to your thoracodorsal. And for the assistant, it's better because the assistant at least can stand on the one side of the patient and you are on the other, and it's easier for that. The thoracodorsal is a reliable option, very good. It is a problem when, of course, there was a previous operation there, and there's fibrosis in that region. You may not know if the thoracodorsal was ligated during axillary lymph node dissection or, during DXT. So those are some of the things. But, I mean, if you are doing the patient immediate and there is a lymph node dissection and it is exposed, it's right there, those are, you may use it. Other things that may be thrown are thoracoacromium that can be used, or the axillary artery itself directly, that can be used as some of the others that I mentioned. But you would stick on those 2, internal memory and the thoracodorsal. So I think we've covered the back. Oh, no, we've not completely done the abdomen. The other option then is a dip. Beautiful, procedure that you can do. The advantages over the tram. So whenever we compare the abdominal flaps amongst each other, what you compare them on that will rank is 1, the mobility as per the abdominal strength. So with the tram, you take the muscle. Of course, there's you would classify it MS1, MS2, MS2, and MS0 as well. But with the dip, you don't take any muscle. So with regards to abdominal strength, that one would rate much higher. However, the disadvantages is mentioned is the rate of fat necrosis is much higher with a DIP rather than a tram flap. So as we had with a tram flap, there was a HATRAM criteria. There must be some form of criteria for a DIP, and the criteria that we use there is the Nahabedian criteria. Nahabedian, Nahabedian, Nahabedian criteria, where it looks at the volume. So when you require, greater than 800 grams, when you look at also the abdominal fat, it would rank much higher if the patient, has mild to moderate abdominal fat. And then, of course, your vessel diameter, as we've mentioned, it must be greater than 1.5 millimeters. That is the Nahabedian criteria. Volume and vessel are the ones that rank higher there. So that would be your abdominal flaps that you then use. Then we can move to the back. What do we have at the back? The back, we've got the latissimus dorsi. And the disadvantages, of course, would be the position of the patient, positioning the patient. You might need to change to a lateral or a prone position to raise it, and the mobility of removing such an extensive muscle, especially in patients who are swimmers, skiing. It's a big mobility for such patients. But if you require it, it is a good option that's available. And if you want to increase volume, you would then do an extended lat, of course, either via the T incision or the normal skin pedal, but you bevel it out and reach all the other fat pockets, including also the fascia. So that's your options for the back. Then you mentioned the thigh. The options that you have, using the gracilis muscle, like your tag, your VUG, your DAG, your PAP. Those are some of the options. And your lateral thigh perforators, that's also a great option that you have there. And then, of course, we may worry about the bulk in certain patients. The buttock is another option. Those we're speaking of our S gap, your I gap, but we may have issues there with volume. How much can we get? And also the scarring and the defects that you have with time. We sit on our buttocks. That's one of the issues that we may have with our gluteal flaps, and also the pedicle is short, so that may be a problem. We've mentioned other flaps like your Rubens flap that you may use using your deep circumflex iliac artery as your pedicle. So that then I think takes care of our immediate reconstructive options, autologous options that we have. Of course, we have enoplastic, which we will get there. I'm not going to touch on it now. Perhaps let's touch on it just a bit later. Then you've got delayed. So you can do it immediate, or we can do it delayed. Now, when we do it delayed, that's 6 months to 1 year. As a time frame. So if you do it 6 months to 1 year, then it's delayed. The advantages, we've got permanent oncology for this patient, and also DXT. So the patient had an opportunity to undergo the entire treatment. We've got good oncology results. They've had DXT. They've had a chance to heal, and we've avoided radiotherapy on our flap itself. So we've got an opportunity now to go and debride as well, and then bring in healthy tissue to that site. So those are the advantages of delayed. And how do we divide it? The same way as we would then divide the options that we have for immediate recon, which is autologous. We've got the options we've went through, and then enoplastic options, which are implant based. There is then in between something that then comes called delayed immediate, because we've seen that, look, delayed has its advantages, immediate has its great advantages. But the biggest issue that we have with immediate is what? Is permanent histology. So can we not come in between, and have an option that can give us the benefits of both? And that's where the concept of delayed immediate then comes in. So what is delayed immediate? Look, we come in, we do a skin sparing mastectomy, and we put in an expander. Now that is the entry point for delayed immediate. Skin sparing mastectomy, put in an expander. And then this is where the difference then comes in. So the group from New York, from the Memorial Sloan Kettering Cancer Center, which is MSKCC. This is the MD Anderson from Texas. What the MSKCC then says is, what we then do after we've done our skin sparing mastectomy and put in the expander, we then wait for the histology, all of us. Once we've acquired and gotten the histology, the permanent histology, we then exchange the expander to an implant, and we then radiate the implant. That's what the MSKCC then says. But MD Anderson, they say, no. We receive the histology. When the histology has come back, then we know we require radiotherapy. We don't use an implant. We then deflate our expander that is already there. And what do we then do? We radiate the expander. But why do we deflate it? The reason or the rationale that they use is that they say, no. When we deflate it, we don't have any interruptions from this external beam reaching the chest wall and the internal mammary lymph nodes. So that's their rationale. So they deflate it, and after the entire radiotherapy is completed, the patient has received the total dose, all the fractions, they then re-inflate the expander, and after will then exchange to an implant. When they are done, they will then exchange to an implant. Now, what is then this big thing about, the exchanging to an implant? We will then go into alloplastic. So let's speak about alloplastic since we are there. Now, alloplastic repair, now we have talks about premuscular, but when we speak about alloplastic, we speak about two things. Either you do it immediately, DTI, we call it direct to implant. We take the patient and we put an implant immediately, or we go for 2 stages with an expander. Now, those who say DTI, the problem with a direct to implant, of course, is you don't know what volume you have. You don't have real control over eventual volume. Also, the main worry is flap viability. You've done, the flaps are completely thin. You've operated with this new surgeon that you don't know. You've got thin flaps, and then you put in this implant that is there. You've got opposing forces, and so what then happens? You may have skin necrosis. But of course, we do have now ways of monitoring this where we can use fluorescent angiography, and in essence, these are using your modern equipment like your SPY Elite system, your FLAIR system, your Fluorobeam 800 system, and what they do, you use your indocyanide green dye, and that is injected there, and then you basically looking and using these to assess the vascularity of your flaps, and if you find them that they are vascular, you then put in the implant. But what is then the advantages of going for a 2-stage with the expander? The main advantage is you have control over your reconstruction. You go in, you inflate it 10%, and then you keep inflating. Then you look at the other price, you inflate, you've got control versus your DTI where you have less control, you've committed in the initial stage. And of course, then when we speak about alloplastic, we then speak about the pockets. It can be total, muscular covered by the pectoralis major, or it can be over the pectoralis major. We're speaking about that, this premuscular now, there seems to be talk. And then you can use your dermal matrix, your ADM. You can use it fully to cover the entire implant, or as just partially along the IMF. And we've seen the love of it now is, of course, the contracture rates are said to be less with using ADM. However, we've seen the seroma rates are much higher Infection is a control, and the cost availability is then another problem with that. So those are your main recons when we speak about alloplastic. Either you go for an implant immediately, or you go for an expander and have better control. And of course, something that's often forgotten. Remember, patient breast reconstruction, it can be immediate, it can be delayed immediate, or it can be delayed. What are the options? The options are autologous or alloplastic. We know the benefits of autologous and the benefits of alloplastic. Autologous options, you will base it on anatomical site, the back, the abdomen, the thigh, the gluteal regions. Alloplastic, we base it on either implant immediately or two-stage with the expander. Of course, you can then mix the two. You put in your expander and you can put in the autologous. But once you do that, you gain the benefit of the autologous repair. And the last but not least, which is often forgotten, is your nipple areola reconstruction. Let's start off. Usually that we would do it about 3 to 6 months after our recon. Then for the nipple, we divide it into 3. We can either go for tattooing, which is 2D or 3D, or we go for flaps, or for a graft. What are the options that we can use for a flap? There are different options. You just pick one. The most commonly used is your CV, but a skate flap, your star, whichever option is there are many. You then choose one for your nipple areola complex. What we know about them is that in 2 years, 50 to 70% flattening will be seen with them. And why is that? Well, we think there's internal and external retraction forces from the surrounding tissue. The flap itself, the shrinkage from that due to inadequate subcutaneous fat, poor design, or just normal tissue memory as a cause for it to flatten. So what do we then do? We've got options of grafts. What are grafts? We can either add cartilage that's there, but it gives you your firm, unnatural feel, and the problem is extrusion. There's ADM that you can add. There are fillers that we can add, or fat grafting that is now done. But the option for a graft that has been used and works quite well is nipple sharing. So if you've got quite a long nipple, we will then cut the nipple in half and use the top part for the other breast and purse string the other one. Or if it's a short nipple but broad, we will then take a wedge of that or cut the one in half and then fold it over and close on the one side or suture it together and then use the other on the other side. So those are some of the options that we have. And for the areola, you can either tattoo it where it's 2D or 3D. 3D, you see the Montgomery glands, it's done in that way, or a skin graft that we can put. And what are the sites that we use for the skin graft? I know people who say the labia. No, now we use it's either inner thigh or the lower abdomen. I like the lower abdomen as a site that we can use. And that is your nipple areola recon and breast reconstruction succinctly. I hope this was useful. Thank you very much.